Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and today I want to drop into neutropenic fever. Neutropenia is defined as an absolute neutrophil count less than 500 or less than 1,000 cells with a predicted decline to less than 500. We know that neutrophils are really important because of their role in combating infection. As these cells drop due to chemotherapy, we become more immunosuppressed. Patients with neutropenia can get very sick very quickly because of that blunted immune response, and so fevers need to be taken really seriously. Neutropenic fever is defined as any temperature over 38.3 plus an absolute neutrophil count less than 500, or again, that expected fall to less than 500 in the next 48 hours. It is a common complicating problem with chemotherapy. Up to 50% of patients with a solid malignancy and over 80% of patients with a hematologic malignancy will experience neutropenia and neutropenic fever at some point in their course. And there's a high mortality associated with neutropenic fever as well. That mortality rate can reach 90% without antibiotics. We don't really work in that time period anymore, so we don't have to worry about that group. But even when early antibiotics are initiated, the mortality rate can be somewhere in the 2 to 15% range. The pathogens implicated in neutropenic fever is kind of interesting. This used to be mostly gram-negative organisms. We believe they were translocated from the gut. But since the 1990s, when fluoroquinolone prophylaxis has been very common, gram-positives are actually becoming much more common as the cause of neutropenic fever. Now, of course, we have a shift back to gram-negatives as the antibiotic resistance to a lot of the agents we use for prophylaxis is becoming higher. And so now it can be either gram-negative or gram-positive, and this helps to dictate what we're going to use for antibiotics in this group of patients as well. When a patient on chemotherapy presents with a fever, we're going to start with our initial resuscitation if necessary. Obviously, if the patient's in septic shock, if they're hypotensive, we're going to give them fluids and vasoactives, and we're going to start broad spectrum antibiotics. But honestly, most of these patients don't come in florid sepsis. They come in simply because they have a fever and they've been told that any fever should prompt a visit to the emergency department. In addition to some of the usual labs that we're going to get on patients, things like a CBC and a basic metabolic panel, we also want to get blood cultures here. And you want to get a couple. 2 peripheral blood cultures is a good start. If the patient has any indwelling catheters, you're going to want to get a blood culture off of those as well. The rest of your lab and imaging evaluation is going to depend on what other symptoms the patient has. If the patient has respiratory symptoms, you're going to get a chest x-ray. You might get sputum cultures or a viral swab. If the patient has dysuria, obviously a urinalysis and a urine culture. And if the patient has significant abdominal pain, you're going to want to get a CT of the abdomen and pelvis. If they have diarrhea present in addition to abdominal pain, consider getting a C. diff PCR. Of course, a lot of these patients come in with just fever and no focal symptoms, and we cast our net pretty broad here. We're going to get the urinalysis and the urine culture and the chest x-ray. The CT abdomen pelvis is one place where we're going to probably not do that unless there are specific signs and symptoms pointing us in that direction. In addition to the usual things that cause fever and cause sepsis, there are a couple of specific ones we have to think about in neutropenia. The first is mucositis. Mucositis is a high-risk feature indicative of bacterial invasion through the thin mucous membranes. The signs and symptoms are typically oral pain or erythema. They might have edema. They can have sinus pain, rectal pain. All of these things are important considerations for mucositis. Another unusual one to think about is neutropenic enterocolitis or typhlitis. This is a feared complication in neutropenic fever. It's due to direct bacterial invasion of the intestinal mucosa, and it can cause necrotizing infection. The most common location for this is at the ileocecal junction. The classic triad is neutropenia, fever, and right lower quadrant pain. The patient's pain won't always be in the right lower quadrant. They might not be remarkably tender, but this is why we set the threshold very low. If the patient has neutropenia and a fever and complains of abdominal pain, I am probably going to get an abdomen pelvis CT because we don't want to miss typhlitis. In most of these patients, surgery can be avoided. Broad spectrum antibiotics is the way to go, but if there's a bowel perforation, you do want to get surgery on board early. The majority of these patients can be admitted to the hospital and go to whatever level of isolation is specified by your hospital, but there are certain high-risk features to keep an eye out for. Obviously, things like hemodynamic instability, if the patient has an ANC less than 100, if the patient has a number of other medical comorbidities, if the patient's had a stem cell transplant, these are higher risk features that should prompt consideration for a higher level of care to keep a close eye on these patients. There are some scores out there like the MASC and CISNY risk calculators that help you to determine whether the patient could actually go home with oral antibiotic therapy and close follow-up. But a lot of this is going to depend on your institution, your oncology team, and the patient's means, their ability to get back to the hospital if they need to. Most places I've worked don't really follow an outpatient strategy. By the time the patient gets to the ED, they're probably going to get admitted for IV antibiotics, but don't be surprised to find out that your hospital actually has one of these systems in place to send low-risk patients home with close follow-up. We will put those risk calculators in the show notes for people to check out. We mentioned earlier that if the patient has any hemodynamic instability, we're going to go with broad-spectrum antibiotics. But in the patient who's hemodynamically stable, maybe they don't have any big high-risk factors, you do want to think carefully about that antibiotic selection. If the patient has old cultures from prior infections, that can help to guide your management. Most likely your hospital will have a protocol as to what agents are preferred, and that's your backup of what you're going to use. Most of these guidelines have a single broad-spectrum agent that includes pseudomonal coverage, something like cefepime or piptazo, maybe a carbapenem, and then we have to consider vancomycin use. Everyone doesn't need vancomycin use, but if the patient has signs of mucositis or cellulitis, if they have an indwelling catheter, they've had prior MRSA infection, or if they're already on prophylaxis for gram-negatives, you're going to want to add that vancomycin on top of your gram-negative coverage. There are a number of additional antibiotics to consider based on patient risk factors and prior infections. We've got MRSA covered with vancomycin, but depending on the patient, they could also have VRE, and you might have to think about linezolid or daptomycin as your backups. Many of these patients will have had sepsis in the past with an extended spectrum beta-lactamase producing organism. In that case, a carbapenem is usually going to be your go-to. You might also use tigecycline. Again, this is going to depend on your institution. In general, if the patient is stable, or once I get the patient stabilized, I'm going to call up my infectious disease colleagues. I'm going to talk to them about the patient, and they're going to help to guide me on exactly what is the best therapy for the patient I'm looking at. Before we wrap up for the week, let's hit some big take-home points. Febrile neutropenia is a condition conveying a high mortality and morbidity. It is critical for us to identify this, start broad-spectrum antibiotics, do the proper workup, and then talk to our consultants for further guidance. If the patient has an ANC less than 500 or a predicted drop in the ANC to less than 500 in the next 48 hours and a fever, they're going to qualify for neutropenic fever, and we have to manage this group of patients very aggressively. Remember to check old cultures and obtain new cultures prior to starting treatment. And finally, if your hospital has protocols on managing neutropenic fever, make sure to check those out. Talk to your consultants to help to guide your further management. All right, that's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks on our cast. In the meantime, don't forget to pop on over the site, check out all the great posts from our faculty, and until next time, stay safe.